Hello, this is Fernando Gómez Sancha, and this is probably going to be the last video of the year 2023 because Christmas is coming and probably I will rest. But I have this nice video of a mid-sized prostate, and it is a nice video to reflect again on some aspects of the Bloc technique with early apical release and sphincter's mucosal preservation that might be of interest for those of you who are trying to learn and improve your technique of enucleation. Normally when I start, I do a very brief cystoscopy. I don't want to force too much and cause bleeding. And I try to put the fiber at 6 o'clock, and I tend to focus on the fiber. That is the localization of the edge of the sphincter at 12 o'clock. And here I'm doing the white line on the right side of the patient. On this side I'm deepening it already. And this is something that you can do when you do your white line and you have good visibility, because many times there's mucosal bleeding and you don't see very well. But if you see very well, you can do some deepening of the white line at the beginning. It's going to ease quite a lot the apical liberation if you do. Okay, so like I'm doing here, just make it a little bit deeper. Of course, respect the mucosal edge that you have already marked. You can see the sphincter is perfectly safe, but you see you can deepen it along the edge of the mucosa to make it easier to dissect the apex. Okay, so now this is now the entry into the plane. I was probably showing people, or there was someone in the operating room, and I was showing how sometimes you can do a little bit of a mechanical push to try to identify the proper plane. Although I no longer care so much about seeing a beautiful plane, because often you want to see a beautiful plane and you have to settle for a capsular plane. And a capsular plane is a plane that looks capsular. Here, for example, the pushing was not very effective, so I decided not to push, because I try to be extremely gentle with all my movements and all the things I do during HoLEP, trying not to stretch the sphincter, trying not to... So it's a very, very delicate manipulation of the scope. Now this is a connection of both spaces to try to develop the posterior line. You see here, I'm more and more thinking of the prostate like a little box, you know, and so I have this posterior line that I developed at the beginning of the operation, trying to do very wide movements going from side to side, you see, almost like that, because this is a way to construct a uniform line. If you do very short movements, you will deepen the incision in one small region. But if you do wide movements like this, you see you are defining a very uniform line of dissection that is easy to recognize and that it's easy to follow. Here, often the posterior plane doesn't go down too much, so you have to aim a little bit, I would say, upwards, almost from the beginning. So when you cut the frenulum of the vario, I think the plane starts going up a little bit. If you think that you missed the plane, you can always recheck, you know, go a little bit deeper and re-explore the plane. If when you re-explore you start seeing that you're deepening in the peripheral zone, then of course you can correct again. But you will see in this operation how many times we challenge the plane, but again, always trying to construct a uniform line that is going to be good for orientation. This is the way you see we have a very clear landmark of where the sphincter is, where the apex is. In this case, I'm not deepening the white line because I already did it before. But then I'm starting to define the initiation of the lateral line. I remember the prostate is a boxy structure. This would be the beginning of the lateral line. This is what I call the mobilization phase. I mobilize the apex posteriorly. Here you see the mucosa, and I will try to stick, and I will try to detach the mucosa from the apex like this, getting under it, trying to make sure that we preserve that mucosa of the sphincter, and we don't produce this infamous flap at 12 o'clock. So you see that we did an initial dissection of the lateral plane, the mobilize and connect phase. Now we are going a little bit further up. I always try to connect. You see, connecting the lines, the posterior line with the lateral line, is important because you need an orientation system. And here I'm trying to go further up. You see here I'm trying to find the best possible position. I tried to cut initially the most distal attachments here, you see, because if you go deeper and you try to dissect towards the 12 o'clock region, you're going to stretch the sphincter. But if you cut the attachments of the sphincter to the apex apically first, and then you dissect a little bit towards the bladder neck to gain some mobility of the apex, then you're going to be very safe. You're going to be very safe. There we are, coming up and coming down. You see, all the movements are quite long, are quite wide, because we want to generate long lines of dissection that we can perfectly distinguish. That's the 12 o'clock. Let's go to the other side. This is a little bit more deepening of the white line. It doesn't matter if you cut on the anoma a little bit, because we are going to then go to look for the deeper, deepest possible lateral line, lateral plane. Here I'm trying to define the lateral line. This is the phase I call mobilize and connect. So you mobilize the apex and connect the line that you are generating, the lateral line, with the posterior line. Mostly what I do is I develop the lateral line connected to the posterior line, so the posterior dissection I did defines how deep I go in this phase. And then apically cut the attachments of the sphincter. You see here, there's some mucosa as well, so you have to remain there carefully. There's a little bit of 12 o'clock flap forming, but we don't want it to be, because we are detaching this sphincter's mucosa from the mucosa, if you understand what I mean. So here again, coming up slowly, trying to see where is the 12 o'clock region. This is a little bit of incision at 12 o'clock. Often when you cut these attachments, there is the possibility of letting the sphincter go backwards. It tends to go a little bit backwards. We get some access. This is what I call the horizontal access incision, like this. You see, it doesn't matter if you cut a little bit on the apex, because then we're going to go and look for the uppermost plane possible. There we are. Probably hear some incoming messages. I'm sorry for that. So again, what I'm trying to do is to perform an ascending dissection. So I go from 6 o'clock to 12 o'clock in one side, then again from 6 o'clock to 12 o'clock on the other side. The liberation of the apex gives it some mobility, so it can descend. And when the apex descends, accessing this area is much safer and much more feasible, much more easy. And you see that I'm going up now a lot with my dissection, because I don't want to leave apical anterior tissue. You see, many colleagues try to preserve like 1 centimeter, 2 centimeter of the anterior apical tissue. I try to liberate the mucosa, and then here there's some confusion. There's some BPH tissue there, so we have to clarify what's going on. So often, you see, I'm not shy to explore what's going on with the plane. I try to understand, and that means, many times when you're not satisfied with the quality of the capsular plane and you think that there's some adenoma staying attached to the capsular plane, then you can explore. You can try to go back and check what's going on, try to find out, you see, if there's a deeper plane that you can develop. In this case, I was coming in the middle, but now when you go from the side again, I will try to connect. So always looking for the most extrinsic, most peripheral line that you can follow, and trying to get satisfied in the sense that the quality of the plane is good enough. Okay, here you see sometimes the anterior dissection might be a little bit confusing, and as I said, I never leave anterior tissue close to the sphincter for safety. It is very, very safe to remove it all. I think, especially with this en bloc technique and the apical liberation, it is perfectly feasible to go all the way up and to try to remove all the anterior tissue that you could find apically, and then of course progress towards the bladder neck. Here you see often you need to go sideways to check where's the plane coming, and then follow that line, follow that depth, because we already know how this anatomy works. As I said, often, you know, we see a lot of MRIs and we understand very well. And here you see, this is an example. I'm digging and digging, trying to find out if I removed all the anterior BPH tissue. So I don't mind re-exploring the lines and deepening my dissection to make sure that we are thorough and we are radical in the removal of the adenomatous tissue. Some planes open beautifully, and you don't need to, you know, do much effort to stay on the deepest possible plane, you know, the capsular plane. But sometimes you have to re-evaluate, re-establish, and always trying to connect, you know, to the other side. So here you see that I am trying to find the best possible anterior plane when I'm not satisfied with the depth that we are achieving. Now here the lines connect, and I go up, 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 up to stay as anterior, as capsular as possible. And then of course we have to work a little to make these lines connect, to make these lines continuous by doing these broad dissection movements, trying to make my life easier for later. When you do several depths and several, you know, explorative incisions in the prostate, you need to find some order, you know, in the chaos that you are starting to form. So spend some time constructing lines that you can then recognize and follow. This is my advice. And there we are, you see, trying to understand. Sometimes you get carried away dissecting the anterior plane, and there's a lot of lateral plane still to develop. But you see, now we're getting comfortable, and there's a nice line that we can follow. You see that it is very, very nice to have this optimal visibility throughout the procedure. And that is, of course, because this pulse modulation, the virtual basket, is very good for hemostasis. It's very hemostatic. But also because the en bloc technique irrigates a very small space. So if there is a bleeder, we're going to wash out the blood, and we will keep seeing very well. So this is one of the main advantages of the en bloc technique. There, for a moment, I briefly saw that I was going a little bit deep. So when you dissect the plane, and you see that I don't mind passing once and twice and 3 times, I choose a very soft dissection effect that doesn't penetrate too much, because with successive passes I can evaluate the depth. You see there was a little bit of deepening in the plane, so that allows me to recognize early and to change my direction. There you see there was a deepening area, but I got closer to the adenoma. I targeted closer to the adenoma, so I don't continue digging in this deeper aspect, and I correct my plane. So this is fundamental. You have to be totally concentrated on watching the images The information we get is not complete in the sense that often we don't know exactly what is the good plane. If you see one of these photograms, it would be difficult to know what is plane and what is adenoma, but of course we have memory and we can remember what we have seen before, where we're coming, where we're going to, and then we get these lines, and the lines are very nice because we know the shape of these lines and we trust the shape of these lines to do the dissection. Of course, we get reassuring images like, you know, we see that the line is uniform, the plane looks capsular because it's white, because it's smooth, because there are fibers on the surface, and everything is coherent. You see the depth of the plane, the way that the anterior line and the lateral line connect, and this way we can progress with our dissection. Also notice how this technique allows you to work continuously. And the nice aspect of having very beautiful lines, constructing these lines, is that you don't need to stop too much to watch, to know where you are. You know, the lines are telling you, and this is the pathognomonic sign that we are reaching the bladder neck. Probably here I wanted to liberate a little bit better the lateral aspect before going in the bladder. And but you see, if we look at this video, you see most of the time I am firing the laser, and every second I am detaching adenoma from capsule, which means that time efficiency is going to be great. I don't move very fast. I don't rush the operation. I don't need to rush. Rushing it too much might become dangerous, you know, even when you are experienced. I don't like to go very fast. I like to go slowly, steadily, you know, but that every movement I make has a meaning, you know, and has some sense and is advancing the operation. So, as we are approaching Christmas, I'm going to give you a present, and the present is a detailed explanation of how to negotiate the changing direction of the plane with a straight fiber. You see the anterior plane, what we're doing is quite simple. I'm just following the curvature of the bladder neck, you know, coming downwards towards 6 o'clock. It's interesting to point out that at the apex we did an ascending dissection. So we went from 6 to 12 in both sides and connected at 12. And here we're going from 12 to 6 in both sides, and we will connect at 6. So it's the opposite strategy when we are closer to the bladder neck. Always we have to check the UOs because they are important. Ideally, we don't want to hit the UOs. It is not the end of the world. Most patients that I have seen in my life where the UO was a little bit damaged by the holmium energy did okay. They didn't have any trouble with that. I didn't need to put a double J stent or anything like that. But of course, it's always better if you don't hit the UO, because then, of course, there's much less risk. So this technique also offers you the opportunity to go inside and check when you are approaching this region. So now this is the explanation I'm trying to show you. So in order to dissect this plane, you see that the fiber now it's becoming very perpendicular to the capsule. You see, we have to use a special trick. And this is the idea. If the plane is perpendicular to the fiber and you fire against the line of dissection, you're going to deepen in the capsule, and that's dangerous. So when we do the posterior plane and when we approach the bladder neck, we have to get closer to the side of the adenoma. We don't fire against the line of dissection, we fire outside. And then you're going to be able to break the attachments and continue the operation with safety to the capsule. So my recommendation, in the first half of the operation, target the line. And in the second half of the operation, target closer to the adenoma. It's like a motor cycle, how do you say, pilot, when he takes the curves, he gets closer to the curve, you know, to the. So here, as you can see, my fiber is not targeting the line of dissection because that would be firing directly on the capsule. I'm targeting a little bit closer to the adenoma, and with every move, you see, if I go towards the left and then to the right, I'm doing like a zigzag movement. You see, I'm going a little bit further up with my fiber to try to stay on the good plane and try not to perforate into the capsule. So I think this trick is good for all kinds of lasers, and of course it works wonderfully well with holmium. You see that I keep the fiber at 12 o'clock in this moment because I can push up a little bit with the tip of the scope and the fiber to expose the line of dissection, and then I try to target excuse me, a little bit further up, always going up against the edge of the adenoma. And this is my Christmas present. If you understand this, you're going to be so much safer with your HoLEPs, you know, and with your enucleations. And this is a central concept of enucleation. This is, of course, the posterior plane, but you can use the same principle or apply the same principle on the lateral side. And here you see, here we are trying to get to see the bladder neck on the side. You see, we're trying to reach that region. I keep up, keep my energy in the side of the adenoma, trying to have a smooth dissection effect so I don't perforate. And usually it's possible. Here I'm checking the UO again. Of course, my lens is 30 degrees and I'm looking upside down, so it's a little bit more tricky to see the UO. Sometimes I even turn the fiber to 6 o'clock to see the UO, because then the 30-degree lens is helping me. And here again, you see how I very subtly stay upwards closer to the edge of the adenoma than not firing straight into the line of dissection. So the idea, if you can go from the sides like this, check that you reach the bladder neck on one side and the other side, then the pedicle at 6 o'clock is quite small, quite, how do you say that, not very wide, and narrow. This is the word I was missing. And that will allow you to tilt the adenoma. So I try to lift. You see, it's not enough. I don't want to make any force, so I'm gaining millimeters of liberation and gaining mobility to try to make sure that I can lift this adenoma without using too much force or anything. Just lift it. Once you lift it like that, and in order to facilitate the lift, I'm going to cut these fibers that I can see very clearly now. Of course, I keep close to the upper part, and I think this is one final check, because if you try to push the adenoma too early, you see here I can lift it, and then when I push it, it goes easily into the bladder. You see now the prostate has rotated, and I have much better access in this side. You see here it is really, really simple to finalize, you know, cutting this, dissecting these attachments. Of course, I do a very, very gentle push, because if these attachments are still significant, when you push the contralateral side, you can be pulling from these fibers, you know, and then I have seen capsular perforations, not because the laser did it, but because I pushed too hard from the other side and pulled these fibers and broke a very thin capsule. Now, here I'm completing the rotational movement of the prostate. So I'm pushing from left in the camera to right to make sure that I can tilt the adenoma into the bladder. The prostate goes inside rotated. That's why we manage to push the adenoma into the bladder. Many people without experience with Bloc say, with Bloc you cannot do big prostates, because when you push the adenoma into the bladder, the prostate is bigger than the bladder neck. But the truth is, if you use this trick, you know, you release most of the posterior aspect, and then you rotate the adenoma. It goes sideways into the bladder, and we can tilt huge prostates without much problem. If you found problems there, there's always a chance to split it in two. This splitting of the adenoma would be absolutely bloodless and fast, and then you can push one lobe and then the other lobe. This is not the end of the world, and only very occasionally I need to do that. Again, look how the UO is getting closer to us, or we are getting closer to the UO. So we have to be careful in this final detachment. Also, you see there is a risk to go retrotracheal. So, well, but you see the key of this operation is to recognize things when they are not too bad and avoid making them too bad. You know, so if you're careful with the energy settings you use, well, the energy settings only determine how the energy comes out of the fiber. So it's not the settings, it's how you use this energy to get a soft dissection effect that is not too aggressive and too dangerous. And there we are, finalizing the dissection. That's the end of the operation. You see that we had a very nice capsular plane. Hemostasis has been good throughout the operation, and we managed to stay in the capsular plane and not go too deep. Let's check the fossa. The fossa looks beautiful. The veru, and when we look at the sphincter, it's looking really, really good. You see, it's looking really, really good. We managed to keep the mucosa on the sphincter, so we know that this patient is going to be perfectly continent. There is some tissue there at 12 o'clock. Let's see if we can remove it to make it look better, and so we don't have a nodule there. But of course we need to be careful with the UOs. And you see this has been 27 minutes. It's not a race, we don't want to be breaking records, but if you develop the skills, and I would recommend you to try to train your skill, to become more efficient, to be able to work continuously, to make sure that every second, every minute, the operation is moving forward. You see, you will be quite fast, and you need half an hour for the enucleation of this prostate. It's not too bad. And you see now, with modern morcellation, the morcellation phase doesn't take too long. So it is really, really nice, this procedure, and it is very wonderful to put a catheter. There's no bleeding. Patients go home very fast, and they're very happy, and the procedure is durable. So you fall in love with this procedure. This was the change of the instrument. I took out the cystoscope to put in the nephroscope, and morcellation will start. Domestic video has these things. You probably hear someone is handling plates in my kitchen nearby, so it's part of the soundtrack of this video. And then for morcellation, remember, you don't want to get the blade too close to the camera, because then everything is white. You see the light is saturating the image a lot because of this close proximity to the adenoma. But if you keep the blade a little inside the bladder, it's not dangerous, and you can see that only half of the screen anteriorly is occupied by the adenoma, and the posterior part is occupied in the center by the blade. And you see two black triangles on the sides of the blade. Or, as we are seeing now, we see the edge of the bladder neck. So you see my morcellator blade is not even in the bladder. It's probably, you see, 1 centimeter above the bladder neck, in a very safe position, and morcellation is taking place very, very nicely. I only use one giving set, of water with these instruments. But of course, I'm always very, very careful to see that the engagement of the adenoma with the mouth of the morcellator is good, because I know that when that looks like that, there's very little water coming out. It's just tissue with water, but not too much water, and the entry of water can compensate the outflow. So I can keep on morcellating. Only when the attachment is not good and I can see the inside of the mouth of the blades, then I'm worried that I'm sucking too much water. If I can see it, it's because it's sucking a lot of water. So I stop the morcellation pedal, try to engage the tissue again, and then I activate again. And I'm much more careful with even waiting a little bit for the bladder to refill, palpating the suprapubic area to check that the bladder is tense. You know, I can feel some tension there, which means that the bladder is full, and then the risk of bladder damage is very, very low. I was going to say I don't remember when I did a bladder lesion, but of course you never forget. But I wanted to say it's been a long time without having trouble with morcellation. So morcellation is very safe when you keep the good habits. You know, have good hemostasis, have the blade looking up always away from the bladder, keep the morcellator in the axis of the patient, in the midline, because many times we have the camera system in one side of the patient or the other, and then if you even sit facing the camera, your axis could be wrong. So you keep the instruments always aligned with the midline of the patient, so that you don't get close to the lateral walls of the bladder, and then morcellation is quite safe. It's important to develop this relaxation when you work, and enjoyment. You know, when you do your HoLEPs, you need to be very relaxed and very happy, because you need to get fresh to this final part of the operation, the morcellation. Some people are so anxious and so nervous, and they're so afraid that when they get to this point, they're already wasted, tired. So I think we have to develop this enjoyment, and technical mentality rather than an emotional mentality, fearing that something bad is going to happen. As many beginners see HoLEP, there's always, I call it the black legend, of HoLEP, that HoLEP is very dangerous and something can go wrong, very badly wrong. And I think this is all old-fashioned now, and it can be a very, very safe and enjoyable operation. And I hope you enjoyed this video. So my best wishes to all of you for the 2024. Bye-bye.